Good morning, everybody. Welcome to this session on non-invasive evaluation of vascular imaging. And I thank Dr. N.N. Khanna for having given this opportunity to speak on this topic. It's actually the basic which I'm going to discuss, and my senior colleagues will probably be discussing the arterial and venous Doppler, how it is done. The topic today for me is know your machine, knobs, controls, and transducers. The purpose is to discuss knobology, that is, what probe to use, what button to press in order to obtain good images. Probes are generally described by size and shape of their face. Mainly in doing vascular duplex scan, we are using two probes. One is the linear probe, which is a high frequency probe, frequency varying between 5 to 13 megahertz, and a phase array probe, that is the cardiac probe, which generates electronically steered beam in a closed array, and the frequency is low, that is 2 to 5 megahertz. This is how the linear probe looks like. It is a high frequency. It is better used for superficial structures and vessels. It generates rectangular images, gives a better resolution. The only problem is it has lesser penetration. The uses of this linear probe is it is ideal for viewing the superficial structures, especially if you want to obtain a vascular excess, that is central and peripheral. Our anesthesia colleagues have developed a liking for this probe, and they want to use it for every central line they put in. It is very useful for doing, evaluating deep venous thrombosis, for doing arterial Dopplers, and also it is used by our ultrasonologist friends for evaluating skin, soft tissue structures, tendons, bones, and muscles. The other probe which we are using is a phased array probe. It has closely grouped crystals. Basically, sound waves in it generate from a single point and they fan outside. So the image we see is a sector-like image. The value of this probe comes when we want to see deep-seated structures because it has a more penetration since it is low-frequency probe. It is basically used for cardiac imaging and also for evaluating the intra-abdominal vessels, that is aorta. It's very good for scanning the iliac vessels. First and foremost is when we start the duplex scanning, it is the B-mode imaging, which is also known as the basic grayscale imaging or two-dimensional imaging. It is the standard black and white image which we achieve by B-mode scanning. Now, machine presets. Basically, all ultrasound systems, they have presets which are available to us by the company. First and foremost is you have to press the probe you want to select. That is for, in our system, we have a Philips IE33. So L9 probe is the button I will press, and I will choose what area I want to scan, whether it is the carotid, arterial, or venous. So presets are programmed to optimize images based on certain gain, power settings, focal zones, frame rate, and other settings. So you must choose the correct preset before scanning. Depth is the next button we have to use. It controls how much distance into the body the image displays into the far field. It is important to start deep, not to miss the findings in far field. Once area of interest is identified and far field has been surveyed, the depth can be decreased in order to focus on the area of importance. This is how we have increased the depth to 12. So this is a external iliac artery, superficial femoral artery, and profunda. So first I have increased the depth to see where this is located. Once I know this is the area of interest, I can go down on the depth. So when the depth is decreased, superficial structures will be magnified, which will improve resolution. The depth here is about 3. So you can see this area is magnified and it is a better resolution is there. But when depth is increased, there is wasted space. It affects the quality and frame rate of the image displayed. So we have to adjust the depth to show area of interest in the top 2/3 or 3/4 of the screen. Then comes the gain settings. Gain adjusts how machine listens for return of echoes. Increasing the gain, the strength of returning echoes is amplified, thus brightening the image. And when we decrease the gain, it darkens the image. There are two types of gain which we use. One is the gain button, which is responsible for overall gain, or there is a button called time gain compensation, we can adjust the gain at depth. So there are two sets of knob available in most of the ultrasound system, that is horizontal gain and vertical gain. TGC may be set as a column of sliding knobs or may be adjusted for near gain or far gain. Too much gain will increase noise and wash out image. Other controls are image optimization. In our system, which is IE33, we have a button called iScan. If I press iScan, automatically the gain will be adjusted throughout the image. Zoom button is there, which allows magnification. Focus is, it optimizes the lateral resolution at a given depth. Then comes a button called tissue harmonics. Whenever an echo is reflected off an object, they will return at fundamental frequency. But in harmonics, it becomes multiples of fundamental frequency, which could be 2x or 4x. Higher frequency waves experience less attenuation, less scatter, and they generate clear images. This is a complex formula for Doppler, which the machine automatically calculates for us. We are using basically pulse wave Doppler and color Doppler for most of our duplex scans. What is a color Doppler? It utilizes the pulse echo Doppler flow principle to generate a color image. This image is superimposed on the 2D image. The red-blue color displays provides information regarding direction and velocity of flow. Why use it? It is used to visualize the blood flow and differentiate it from the surrounding tissues. It provides a map for placing the Doppler sample volume. The basic questions are, is there flow present, what direction it is traveling, and how fast it is traveling. Regardless of color, the top of bar represents flow coming towards the scan head, and bottom of the bar represent flow away from the scan head. Flow direction is determined by orientation of the scan head to the vessel or the chamber size. Linear array scan heads, they display a square-shaped color box which steers right to left to provide the Doppler angle. This is the rectangular-shaped color box with the linear probe. You can steer it right or left according to the direction of flow. All other scan heads, that is phase array probe, it displays a sector-shaped color box which is adjusted in position by using a trackball. So this is the sector-shaped color box. The box must approach the vessel or heart chamber at an angle other than 90 degrees. Following the Doppler principle, there will be no color or little color displayed at a perpendicular incidence. Velocity of flow can be judged by the color. Normally, if there is turbulence, you can guess that velocity is increased and this area may be having a stenosis. And these are the basic controls for color flow, that is color gain, scale, wall filter, steer. These are the basic things we use for optimizing the color. Color gain is the function of the receiver. It adjusts the amplitude of received echoes. Focus zone, as I've said, for the lateral gain. This is the area which it is focusing. Color box. Due to shortage of time, I'm just rushing through my slides. So challenges with color is deep vessels. It is difficult for colors if the patient is it's a larger patient or an obese patient, or if the vessels are deep. Then if the vessels are very small, if they are very slow flow rates, and if they are flash artifacts. What defines a good color? When color fills the entire vessel or chamber inside the wall, and color does not override the wall. Frame rates should be adjusted adequately to accurately display the color flows. So the #1 rule of duplex scanning is always begin with a good 2D image before turning on the color. Thank you very much for patient listening. If there are any questions, I'll be more than happy to answer.
So the vessel is heavily calcified. What is the precautions we should take and limitations of the image?
If the vessel is heavily calcified, first and all, is the good B-mode imaging is important. You have to adjust the gain settings so that you can visualize the vessel. And sometimes when you put the color in a highly calcified vessel, you may not see any color. In those particular cases, I would use a pulse wave Doppler to assess the velocity and see whether the vessel is flowing or it is not flowing. So B-mode imaging and use of pulse wave is very important in calcified vessels.
Any questions from the audience? Yep.
Yeah, hi. Thanks, Dr. Minocha. I'm Dr. Bedi from Christian Medical College, Ludhiana. Now, since we ask for a number of Doppler investigations after surgery, so could you tell us any tips for the ultrasonographer to look for any changes that you're going to look for, anything that you can miss? Sometimes the reports are not, there's turbulent flow, which you expect, and that is sort of told in a very ambiguous way to the patient. So is there any tips how to look for color Doppler in a patient post-operative, for example, surgical or after a stent? And number two question is, if you have a stent in position, does that affect the quality of the image?
First and foremost, it depends whether you ordered for a arterial Doppler or a venous surgery. First and foremost, the person who's conducting the Doppler must know the background, why this patient has come to me, what I'm going to look for. So firstly, the basic arterial, the native vessels are to be scanned, and then you have to look for whether there are any grafts in place, like aortoiliac bypasses or fem-pop grafts. The native vessel and the graft scanning you have to do. It is very important to identify the area of anastomosis proximally and distally to see for any stenosis there. And plus the distal vessels are to be scanned for seeing the quality of flow after the graft. And there are a lot of requests for Dopplers, venous Dopplers, especially in post-varicose vein surgery. So in those cases, we have to see for the patency of the GSV, the great saphenous vein, and plus identify the perforators which have been missed out on the first go by the person who's conducted the laser scan. So history is very, very important, and you should basically know what you're looking for. If you have if the interventionist has a particular thing in mind, he should inform that thing to the person who's doing the Doppler so that specific thing can be looked for. Otherwise, sometimes what you are actually aiming for can be missed by the person who's doing the Doppler.
Thank you, Dr. Sikhi. Due to shortage of time, we'll go to the next topic.
Thank you so much.